when you talk to a patient and you decide together with the patient that he can be a candidate for that, you have to have in mind that you are delivered thermal energy. You have to talk to the patient that it's not only one procedure, that you have to offer it in 3 sessions. And at the end, both you and your patient, you are hoping that you can increase the quality of life of the symptoms of the patients and you can get rid of his uncontrolled situation. So before you start, you have to invest like always. You have to buy the Alair controller, and then you need a catheter which have the wire tip, and you need a new wire, you need a new catheter per procedure. So at the end you have to buy per one patient 3 of that catheters. Who should do bronchial thermoplasty? You can read that slide, but also you can go back and read what authorities are recommending, and I think the best recommendation is coming from the UK. The NICE published last year that the treatment should be offered from centers of excellence. So centers where you have IP guys who know how to handle the scopes, but also asthma experts who know how to handle the patient. The companies helps you a lot. They offered you a perfect training model, so you have different ways to learn how to do that procedures, but at the end of the day, you should be sure that the patient is treated in a center of excellence. We want to treat only patient in a stable situation, so you should see the patient before. You should be sure that the patient is really on a stable situation. Due to the reason that we have realized in all endoscopic procedures we are offering on severe obstructive patients that we are inducing a so-called bronchoscopy-induced exacerbation, which is completely unrelated what you are doing, but sticking a scope in a patient which is severe obstructive is end up in a little bit of exacerbation. So we put the patient on oral corticosteroids before the treatment and even at the day of the treatment and a day later. Most of the procedures around the world are done under local anesthesia. We are preferring back home in Germany to give also conscious sedation to the local anesthesia because the procedure is about 45 minutes, and only doing that in local anesthesia can be a little bit hard for the patient and also for you. So we're doing it in local anesthesia with a little bit of conscious sedation. As mentioned, 3 procedures. Each procedure lasts at least 45 minutes. As mentioned, you have to do you have to offer the treatment in 3 sessions. So we always start with the right lower lobe. The second session is then when we treat the left lower lobe, and in the third session you treat the right upper and the left upper lobe. The middle lobe is excluded until now. Initially there have been some concerns regarding maybe web-like stenosis, so to create a middle lobe syndrome. But I think this is something we have to work on if we should include the middle lobe into the future also. So 3 procedures starting the right lower, end up in the both upper lobes. And then, to be honest, it's a boring procedure. You go in with the catheter, you go into the target, you open the catheter, you press the foot switch, beep, 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 then you know you can close it, then you have to retract it for 5 millimeters, you open it again, and you do it again. So from a bronchoscopy standpoint, it's a see one, do one, teach one procedure. But the brain work you have to do during the procedures, you should remember where you already have been. So you have a lot of segments and a lot of sub-segments you have to treat. You have to have that in your mind that you only have to treat one subsegment once. You see, there was contact of the probe, but the contact has 4 areas where the probe takes contact to the wall. You didn't see it at the other spots. So you cannot believe what you're seeing. You have to really remember, I treated already segment 7, now I move to segment 8, to 9, to 10, and back to 6. So it's really the brain work for you not to activate the probe, to remember where you already have been before. So which is the patient population we are talking about? For sure, all the trials showed you we are going for patients with suffering on severe asthma. So here you get the American recommendation. So patients which are still unstable, and you prescribe everything you can prescribe in that field. You have seen that slide before. This is the evidence we have, and I look to the trials in a different way. I look to the trials regarding the in- and exclusion criteria. You see, this is what was written down in the AIR2 trial, and it's still that what the company is recommending. We have to go for severe asthma patient. We only have experience in patients older than 18 years. The patient should stop smoking if he's a smoker, or when you see him the first time. And we really do not want to treat patients which are unstable at the time of the procedure. Contraindication, we have heard that before. For me, the major contraindication is you deliver thermal energy, and therefore everything you can destroy with thermal energy is a contraindication. And as already mentioned before, patients which have had a treatment before with the system should not treat it at the moment again. As mentioned, you have to see the patient a couple of days before the procedure, and sometimes you have to decide, okay, we cannot offer the procedure at the time we scheduled already the procedure. When the patient is developing an active, uncontrolled situation, then my recommendation, or also the recommendation of the company, would be delay the procedure, just reappoint the patient and do the patient a little bit later. And when you have an idea that the patient has bleeding disorder, you should not deliver it. The official recommendation is not using it on patients which are taking anticoagulants and antiplatelet agents. So, but back home, we are doing the procedure even under aspirin, and we haven't seen any severe bleeding complication. We do not haven't seen a mild bleeding complication when you do it on patients suffering with aspirin. So, but it is our local decision that we do that in the way we're doing that. And last not least, also a case from our institution, a female aged 44. She developed asthma in her young adultship, and she has a lot of problems. She was treated with all the different inhalers you can offer here, and which is quite often that we also treat such patients with tiotropium. Even it's off-label in the asthma population at the moment, but I believe we have enough good data published that we also can prescribe that to patients. The patient was on tiotropium but still unstable, and she was referred to us for a bronchial thermoplasty treatment, and we treated her last year, 3 sessions, as I mentioned, 4 weeks between the different sessions. The lung function before, she showed the variability in the peak flow, the FE1 depending between 1.6 up to 2.2 liter, and all the other measurements have been in the way you normally see when you have uncontrolled asthma patient. As mentioned, three treatments within 3 months, and since June 2012 she's stable. I just have seen her 2 weeks before I moved over to Philadelphia, still stable. She hasn't had any emergency visit since that time. The lung function is quite stable, FE1 around 1 liter, and also the peak flow protocol are more or less stable. Patient is happy, I'm happy.